This was a first study that we did. We really didn't know exactly what we were doing. We had Valtrex available to us. There was no Valcyte at that time. Valcyte is ganciclovir. Ganciclovir is effective against cytomegalovirus and herpes virus 6, maybe EBV. Valacyclovir, acyclovir, is effective against Epstein-Barr, but not effective against cytomegalovirus or herpes virus 6. I didn't know the difference. We saw patients with EBV, and I treated patients pharmacokinetically, and some got well and some didn't get well. And then I analyzed the patients, and I was so surprised. Here you can see they start out at about 4. This means they can't keep a job. They can't do very much. This is months. This is 6 months. And these are the patients that in 6 months got better up to 7. They can live. They can do things. They can work. And nothing happened to them. What was going on? Uniquely, the patients who didn't get well had Epstein-Barr virus and cytomegalovirus antibodies, and these that got well had only Epstein-Barr virus. And then began our recognition that subset classification of chronic fatigue syndrome is necessary. And at that time, we recognized that there might be an EBV single virus subset and an EBV co-infection cytomegalovirus subset. And now, of course, we know that there is a third virus in this picture, herpes virus 6, and one has to subset classify, know that you have chronic fatigue syndrome, know that you don't have Lyme disease, know that you don't have adult rheumatic fever, but it's clear that you really need to know what you're doing. If one treats pharmacokinetically appropriately according to subset, and we now have the data, there are really over 200 patients that we've treated now. These are 27 patients with EBV single virus subset, and here we are. This is 6 months now. And the remarkable thing is that these people get well and stay well. This is by energy index point score. Now this is by kilocal per day. I prefer the energy index point score because the kilocal per day is remarkably influenced by the weight of the patient, which alters what one gets as well. What these hearts do is first beat rapidly, and then to work harder, and then they beat less effectively. And one can classify the degree of cardiac involvement by how hard they have to work. How many hours of the day are they at tachycardia? And here they're tachycardic at rest. They have abnormal Holter monitor with T-wave flattenings and T-wave inversions, and some of them, the T-waves are tremendously abnormal, as noted here. Now, what happens to these abnormalities with exercise depends on how long the patient has been ill. If the patient has been ill a little bit, they can sometimes revert. If not, they stay. But all of the patients are better when their heart rate is lessened and their virus infections are modified. So that we believe that this is an abortive herpes virus infection. Moreover, I personally believe that we'll find a lot more disease of unknown etiology when we look for gene products of the tegument of these herpes viruses. It is our propositus at the present time that in order to produce disease, that one has to produce gene products which are present to the middle or late portions of the sequence of the herpes virus replication. This is then a failed latency. CFS has cardiac involvement. There is a constant, intense immunologic activation, and CFS is benefited remarkably with cardiac actual improvement with prolonged antiviral therapy. Some patients can be stopped with medicines completely. Some can need to be maintained with lower dosages, and some will revert if one stops medicines. Thank you very much.
In the cardiac changes that you're seeing and looking at the Holter monitors, there's an increasing interest in looking at heart rate variability domain. Have you found alterations in heart rate variability in those patients as well?
No, there is no. This is heart rate variability personified. Absolutely, no question. Yes.
I presume you inferred your own infection was not there was no co-infection. It was EBV that was responsible as a consequence of the response to valcyclovir.
I was on Valtrex for 6 years.
How did you decide, since you didn't have these other criteria, how long to treat yourself?
Oh, that was quite easy. I'm a belt and suspenders guy, so extraordinarily. I waited until first of all, I had an EBV VCA IgM. The viral capsid antigen, IgM, is recognized in every textbook as complete virus multiplication. You're out to about the 97th or 98th gene product. My IgM disappeared. My EA disappeared. My early antibody to early antigens, about 30 of the first gene products, that went down to complete negative. And being who I am, I continued for about 1.5 years longer than that. So when do you stop? You stop when the patient is able to exercise and when you have a parameter which says that there are not likely to be active multiplication anymore.
Do you think co-infected people have worse disease?
Undoubtedly. They're hardest to treat, yes. Yeah. I'm looking, and we're looking, for the single element which reverses the problem.